ايوه بقول لك الصوت. ها
Hello.
طلعت على الشاشه يعني في دلوقتي.
Hello.
Hello.
How are you?
اسمه ايه بيتكلم وانا مش
Nice having you with us.
to be mute.
Okay, sorry, but there is a mistake in my name and
مفتوحه بس أنا مش
surname.
سامع حاجه.
Yes.
يقول لك mute my audio. مش سامع حاجه.
What is the mistake in your
name and surname?
Okay, we want to correct it. So this is
It's
okay.
possible, if it's possible. Perfect. Fantastic. Real
Okay.
time. Thank you.
Sorry for the mistake.
No, it doesn't matter. Thanks.
It's our pleasure to have you with us.
Yeah. Ready to go.
Okay. Good evening, everyone. It's my pleasure to welcome you all to this EGSSA webinar under the title Arthroscopic Treatment of Proximal humerus fractures. This is a very interesting topic with a lot of new techniques and promising results. That's why we decided to have a full day webinar on this topic. I hope that everyone will benefit from the discussion and you meet the experts in this field, and a lot of discussions will be, and of course, you can raise your hand or send your questions, and we answer your questions during the discussion. It's my pleasure to welcome the guest speakers, Dr. Hani Sayed from Saudi Arabia, Dr. Sharif Al-Ghamli from Egypt, Dr. Claudio Cilmi, I hope I pronounced the name properly, from Italy, and Dr. Christopher White from the States, USA, and Dr. Bassem Flega from Egypt. The moderator of this session will be Dr. Bassem Flega. Thank you very much. You can start, Dr. Bassem, please.
Good evening. First, I'm very happy to welcome our friends from Oklahoma, Chris and Dr. Claudio Cilmi, I hope it's correct, from Italy, and all our other friends, Dr. Hani from Saudi Arabia, Dr. Sharif Al-Ghamli from Egypt. And we will talk about this theme, which is the proximal humeral fractures and its arthroscopic treatment. It's there is not too many literature about this subject, so I'm interested to hear the presentations. First, I want to invite Dr. Hani Al Sayed from Jeddah, Saudi Arabia, to talk about proximal humeral fractures, classification, and overview. Please, Dr. Hani.
Thank you for my invitation for this webinar. My talk today is about proximal humeral fractures, options, and management. Outline, I will describe the anatomy and the classification on brief. I will describe how to investigate the problem and will make some classification and classify the lesion. And decision-making include how to avoid complication, some tips and tricks on ORF of fracture of the proximal humerus. So the anatomy of proximal humerus is a four-part head, greater tuberosity, lesser tuberosity, and shaft, with neck shaft angle is about 130 degree. Humeral head had a retroversion from 9 to 40 degree, is average 20 degree. Establish of proper version is essential for stability and function outcome. This is a very nice study about the blood supply for the proximal humerus. It's about 24 cadaveric frozen shoulders, and you will find that 64 of blood supply of the proximal humerus come from posterior circumflex humeral artery. The mode of trauma, as we all know, it's full on the outstretched hand. The deforming force, the greater tuberosity, go with the supraspinatus and infraspinatus, posterior and medial superior. Lesser tuberosity pulled by the subscapularis medial, and shaft pulled by pectoralis major medial and anterior. Near classification is one of the important classification of the fracture on the proximal humerus. He classifies a fracture into 1 part, 2 part, 3 part, 4 part, valgus impaction. Each 1 part means fracture line with displacement more than 1 centimeters and angulation about 45 degrees. This classification helps us with decision making for the fixation or arthroplasty. AO classification gave number of the proximal humerus 1 and 1, classify into A, B, C. A is extra-articular 2 part, B is extra-articular 3 parts, C is articular 4 parts. So when we see an X-ray, we need how to deal with these fractures. So first, we need to know what is the natural history of the fractures. What happened if we leave the fracture without treatment? So this table is a very good table for a function consequence of the malreduction or a natural history of the proximal humerus. So at the left here, this is the element of the fractures. This is the type of the fracture, and this is the function outcome. If the head is dislocated, it will end with loss of motion. If the head on varus, it will loss of abduction. Head valgus means central impaction. Head on extension, loss of forward flexion. If the head is avascular necrosis or collapse, loss of motion. Greater tuberosity superior displacement mean loss of abduction. Greater tuberosity posterior displacement mean loss of external rotation. Lesser tuberosity anterior displacement mean loss of internal rotation. Rotator cuff tear, loss of motion and pain. This is an important point. So this paper, this risk of avascular necrosis, this paper published by Hertel criteria, Hertel published it on 2004, and he described 3 items: the metaphyseal extension, the medial hinge, and the fracture through the anatomical neck. And the Hertel criteria found that when the metaphyseal extension less than 8 millimeter, medial hinge displaced more than 2 millimeters, and functions through anatomical neck, it means that the risk of avascular necrosis it's reached 97%. So it's an important paper. As you see here, this is the metaphyseal extension. It's more than 9 millimeters. It's good function outcome. But here, metaphyseal extension is less than 8 millimeters, so it's bad outcome. This is the medial hinge non-displaced or displacement less than 2 millimeters, and this is the medial hinge more than 2 millimeters. So we need to know who is the patient, what is his baseline functional, and what is his desire from his shoulder, what is the expectation, and he is cooperative with the physiotherapy or not. So this paper published by Chad et al. On 2017 about the prediction of the mortality in elderly patient with fracture of the proximal humerus. And he found that increase the mortality with the high anesthesia scoring system and with low body mass index. And this is the table of the content. And he found that especially who treated non-operatively with high ASA and low body mass index is high mortality. And low mortality was patient treated at the beginning as the outpatient and later on treated operatively. Any option of operative, arthroplasty or fixation. So what is the option of the treatment? Non-operatively, or ORIF, open reduction internal fixation, or minimally invasive, arthroscopic suturing, or intermedullary nail, arthroplasty, or reverse the shoulder arthroplasty. Arthroscopic, I think it will be included on the following lectures by all my colleagues. So I will talk about all options except arthroscopic. So this is the pyramid of the management. Start with non-operatively, minimally invasive, augmented with ORIF or ORIF, and arthroplasty versus non-operative. So non-operative, what is the indication of non-operative? It's one part or 4 parts was minimal displace or displaced fractures with a high comorbidities, a low demand patient, low compliance, or poor bone quality. What is the protocol? Initial support and pain control and early rehabilitation. This is an important issue, early rehabilitation. So this is near protocol for rehabilitation is a 3 phases. And we'll start physiotherapy after 3 weeks. It's my recommendation. And I think I have a lot of confusion about the time of start physiotherapy was conservative management. So function outcome is about 75% are good to excellent result with start less than 21 days of the physiotherapy post-injury. Surgical treatment to consider when there is a mismatching between the patient expectation and the natural history. You have adult patient and his expectation to make a full range of motion. We cannot tell him that you can go conservative. So we will discuss him with the patient, the function outcome, and what is the expectation of his shoulder. So the indication is displaced, unstable, head split, dislocated or open fracture. And as we mentioned now, we have to discuss the natural history of non-operative fracture, displaced fracture with the patient, and also the complication. We don't need to end with this failure. So we'll also mention how to override this failure. So the RF strategy is a point. First, we have to reduce the dislocated head. And after that, reduce all fragment and restore neck shaft angle, reduce post-tuberosities. And now we will oppose the deforming force, support the comminuted section, and fix starting from good bone to bad bone. We have some pattern of the fractures. First is the valgus fractures, as we see here. We need to disimpact that fragment and elevate the head here. And after that, reduce post-tuberosity on the fragment and following was filling the defect by graft, fibular graft, autograft, allograft, and fix with this plate. As we see here, this is separate screws, one for the lesser tuberosity and one for the greater tuberosity. Second was the varus. It's a very common fractures, and there is a word that you have not leave the OR with the patient on a varus reduction. So how to avoid varus reduction? First, we need to elevate the head, even by periosteal elevator or by putting K-wires and correct the varus. We need to restore this Shenton line or this curve between the posteromedial and the shaft. As we see here, this is a K-wire we use on the reduction. Help the periosteal elevator to maintain the Shenton line. Reduction, the scalker, and use the scalker screw is mandatory. Alternative, as we mentioned, if you have a big posteromedial defect and you cannot restore this fragment or restore this posteromedial calcars, you may put medial plate or use this fibular strut graft and use calcar screws and filling the screws. It's important in a varus. Using IM nail, the central axis of the implant is improves the biomechanics of the fractures. This is advantage of the IM nail. Advantage also is a biological fixation and a small incision. But the disadvantage is on the 3-part or 4-part, you cannot do indirect reduction. It's very difficult. As a tenuous fixation, is very weak fixation through the head. The IM nail. Hemiarthroplasty on a 4-part fracture or a comminuted fracture or fracture dislocation or high risk of avascular necrosis with good rotator cuff, we can do hemiarthroplasty. Reverse shoulder arthroplasty is the same. 4-part fracture, fracture dislocation, high incidence of avascular necrosis, but with massive rotator cuff tear or cuff tendinopathy. So the management, we need to know who is the patient, why we will fix him, and what is his expectation. And this is 2 tables which enumerates each fractures and each functional outcome. And if it go with the patient expectation, so you can go with non-operative management. And if no, you can go with operative. if the patient expectation mismatching the function outcome, so we will have to fix this patient. So our take-home message, we need to understand our patient, who is the patient and what is his expectation, what is his bone quality, recognize the fracture pattern and the deforming force, and choose optimal treatment based on the patient and fracture. And thank you.
Thank you very much, Dr. Hani. You showed us the benefits and complications of open reduction and fixation. Now we will see if arthroscopy can bring more positive points in this problem. So I want to invite Dr. Sharif Al-Ghamri to talk about arthroscopic reduction and transosseous suture fixation of two parts proximal humerus fracture. Please, Doctor.
Dr. Fleka, friends and colleagues, this presentation about the reduction and transosseous suture fixation is from the Shoulder Service Department in Salam International Hospital in Cairo. Next. The majority of the proximal humeral fractures are non-displaced or minimally displaced, allowing for conservative management. Next. Next. The most common displaced two parts proximal humeral fracture is the greater tuberosity. It is displaced either superiorly, as on the left, or posteriorly, as on the right, or both. Next. Posterior displacement can cause loss of external rotation, while superior displacement can lead to limitation of elevation and impingement problems. The treatment options are either conservative, open reduction and fixation, or arthroscopic reduction and fixation. Next. The conservative treatment can lead to malunion, causing limitation of elevation and impingement, as well as limitation of the external rotation, as mentioned before. Next. Open reduction and internal fixation is mainly done using the lag screws in cases of large fragment and good bone, or tension band by fixing the band through the tendon superiorly and the cortical shaft inferiorly, or using a screw for inferior fixation. Next. Also, combined tension band fixation is done by using proximal suture anchors instead of passing the band through the tendon and distal anchorage screw for fixation. Next. In some cases, both lag screws and tension band fixation systems are used together for fixation. Next. Open reduction and internal intraosseous suture fixation of the greater tuberosity, especially in cases with osteoporosis or comminuted fragment, can be the treatment of choice. It is done by passing the suture through the superior edge of head cortical bone and the inferior edge of the shaft cortical bone. Now, thus tying the fragment to the shaft in its anatomical position. Next. What about the arthroscopic treatment? Methods of arthroscopic reduction and internal fixation usually is used in selected cases of mostly young patients and is not used in cases of comminuted fracture or osteoporosis, which is present in about 70% of the cases of fracture. The reason for that is that these methods uses hardware which becomes loose with osteoporotic bone. Next. An arthroscopic technique of transosseous suture fixation of the greater tuberosity fracture was developed 10 years ago and applied for all cases, including osteoporotic patients. Next. The aim is to reduce the upwards and medially displaced greater tuberosity to its anatomical position and making a longitudinal or horizontal transosseous suture fixation or both. Next. 3 reconstruction systems are used. The giant needle suture passing system for the longitudinal suture placement, the wire suture placing system for the horizontal suture placement, and the chop needle is used for pulling the sutures. Next. The arthroscopic surgery is done with the patient in the sitting position. The portals used are the anterior lateral for the instrumentation, the posterior lateral for the scope, posterior medial for water inflow or the intra-articular optic placement, and the anterior medial for the intra-articular instrumentation. While the chop needle suture puller is passed anywhere through the skin to the subacromial space. Next. The longitudinal transosseous suture fixation using the giant needle technique includes 6 steps: reduction and bone fixation, then passing the giant needle suture through the bone, followed by pulling the upper end with the chop needle puller, then the lower end with a hook, and finally tying the suture with a sliding knot. And this will be shown in the next video. Next.
This is a greater tuberosity fracture with about 8 millimeters upwards displacement. The line of fracture is passing between the greater tuberosity and the cartilaginous head. After reposition and fixation of the fracture with K-wires, the giant needle is passed through the skin anterior to the acromion, through the supraspinatus tendon, then through the head about 1 centimeter medial to the fracture line, placing an absorbable suture around the fracture. The chop needle puller is passed through the instrumentation portal, then through the supraspinatus tendon immediately above its insertion to the greater tuberosity to pull the suture from its entrance to the head out through the portal, while the lower end of the suture is pulled out at its exit from the shaft with a hook. The 2 ends are tied outside the joint and pushed as a sliding knot to fix the fracture. After fixation of the fracture, the K-wires are removed. Usually, 2 sutures are used for the fixation. The fixation is tested for stability and the operation is ended.
Next slide. Next
This
slide.
is
The horizontal transosseous suture fixation of the greater tuberosity using the suture wire technique includes 4 steps: reduction of the tuberosity followed by K-wire fixation, then passing an absorbable suture through the head with the suture wire, and finally fixation of the fragment in its anatomical position by the suture and removal of the K-wires, which will be shown in the next video. Next slide.
an arthroscopic pointed hook is passed through in the subacromial space to reduce the tuberosity with the arm in external rotation. Then yet the tuberosity is fixed with 2 K-wires. The suture wire is passed through the head medial to the fracture using a guide. The guide is removed and the wire is controlled for placement. The suture wire is further driven through the head. 2 non-absorbable sutures are placed in the distal wire hole. The wire is then pulled out, leaving the sutures through the head. The posterior suture end is pulled with a ring forceps through the portal. The 2 ends of the other suture are held with a clamp. The anterior end of the suture is pulled out from the anterior lateral portal. A sliding one-way self-locking giant knot is made and driven with a node driver inside the joint. Using the concave node driver, the node is placed in the place wanted to fix the fracture. The node is then blocked by pulling on the loop. The wires are then removed and the other suture is tied for more fixation. The fixation is now secured with 2 sutures.
Next. The postoperative rehabilitation is done by 2 weeks immobilization in a single 2 weeks passive self-assisted exercises. Then checking the bone healing by doing an X-ray. And start 4 weeks combined passive stretching and active self-assisted exercises. And finally, 4 weeks aggressive assisted stretching and strengthening exercises. Next. We reviewed 21 cases with an average follow-up of 31 months of clinical and radiological assessment. There were 15 females, 71%, and 6 males, 29%. The average age was 49 years, between 22 and 69 years. An arthroscopic reduction and transosseous suture fixation repair for displaced 2 parts greater tuberosity fracture was done for all cases. 60% of the cases were patients with osteoporosis. Next. The procedures were done giant needle longitudinal transosseous suture fixation in 13 cases, suture wire horizontal suture fixation in 3 cases, and combined suture was wire horizontal and giant needle longitudinal repair in 5 cases. Next. The results according to NEAR classification is excellent in 19 and satisfactory in 2 cases with no complications. So in conclusion, the arthroscopic transosseous suture fixation of 2 parts greater tuberosity fracture has excellent clinical and radiological outcome. It is applicable in all cases of osteoporosis or bone comminution. It is a 1-day surgery accepted by most of all patients. Next. Thank you. Dr. Fleika, friends and colleagues.
Thank you very much, Dr. Hani, Dr. Sharif, sorry, for this interesting presentation. I am happy to ask Dr. Claudio Cellini from Latina, Italy, who is giving us the honor for the first time to participate in our webinars, to present his talk about experience in arthroscopic treatment of proximal humeral fractures, transosseous augmented technique. Please, Dr. Claudio.
Thank you, Basim, for the kind invitation and presentation to invite me for the present my experience in the transosseous augmented technique. Sorry. There is a problem. Hello. Sorry. No. Sorry, Basim, there is a...
I think it works now. Or
it works?
No, I think you press share screen. No, we don't see you. We don't see the presentation. We see you.
Okay, sorry. You say me, you don't see the... Okay. I hope it works now. Okay, sorry for the inconvenience. Okay, thanks again, Basim. And so our colleagues have yet elucidated the greater fracture avulsion of the greater tuberosity. The only thing that I want to underline is that we can treat the surgery is indicated in case of fracture displacement more than 5 millimeters. The problem of the surgery is that if we have a fracture avulsion of the greater tuberosity, and we can use the screw, in this case of small fragments, we can have the fracture splitting. And so our surgery will fail. For this reason, thanks to the learning from our father, to avoid the fracture splitting, we can use the transosseous approach. And as our father that started to use the transosseous approach open, now we can use it arthroscopically. Some years ago, I published a paper on the arthroscopic transosseous rotator cuff repair. And you know that we can use a different device to perform the bone tunnel. And one of the pioneers, if you have a look to this table and if you have a look to the literature, one of these pioneers is Basim Fliga, that in 2002 published his technique with the giant needle, and the last one was me. The geometry of the tunnel shape is different depending on the tools that we can use to perform the transosseous tunnel, from straightforward to curved or angled. And this is the instrumentation that I usually use. I like the curve tunnel, so I use a tailor stitcher with a super elastic transosseous needle. That is a needle made of nitylon that is able to perform, to create a tunnel 1.9 millimeters in diameter. The problem of the transosseous approach may be the low bone quality. In fact, in this case, warning to use this equipment, because the sutures may progress into the bone, creating the cheese grating effect. For this reason was developed some different augmentations, such as the Elite that I usually use. That is a device made of PEEK with 2 slots at the rear and the front with 8 stabilizing flaps. The rear at the front and at the slot in the front and the rear are essential to load the sutures that you want to pass to repair your cuff. My experience in rotator cuff repair is yet published, so I started to use this device to treat the fracture, to treat the greater tuberosity fracture avulsion when the fragment is really small. And then I'll show you a small video about this technique. For the treatment of fracture avulsion of the greater tuberosity. The illustrative case refers to a 45-year-old male which reported a direct trauma on his right shoulder during sport activity. Surgery was performed under an interscalenic block procedure with the ultrasound aid. Arthroscopy was performed 13 days after the trauma. The current technique is demonstrated in the lateral decubitus position, but can also be performed in the B-chair position. First, diagnostic arthroscopy is performed using a posterior viewing portal to assess the joint. An anterior portal is then created under direct visualization outside in technique without any cannula positioning to clean the articular space. The scope is then moved from the same posterior portal into the subacromial space, usually occupied by blood clots. With use of a spinal needle centered to the lesion and tangent to the fractured area, the superlateral portal is then created. Blood clots are removed with a motorized shaver, and the subacromial space is cleaned also with the use of radio frequencies, so to perfectly identify the fracture. edge of the bony fragment and the crater of the fracture are debrided with the aid of the same tools. An additional infralateral portal performed 2 centimeters below the superior lateral one is then created. Through this portal, the lateral aspect of the humerus is prepared with radio frequencies, removing all soft tissue so to better visualize the bone. We are ready now to perform the transosseous tunnel with a dedicated instrument, the Taylor Stitcher Evo, connected with a super elastic transosseous needle. The lateral entry point is established 2 centimeters below the lateral fracture margin, so to prevent cracking the cortex. Once the tunnel is performed, one PDS suture is passed as a shuttle wire. To avoid any peak stress on the healthy bone below the margin of the fracture, a cortical lateral augmentation named Elite is employed. 3 different sutures, 2 tapes, and 1 non-absorbable braided cord-like suture initially loaded into the front eyelet of this peak implant are passed. In the external eyelet of the implant, a violet vehicle was positioned. It will be used later to laterally shuttle the medial sutures, so to achieve a repair in a closed loop. The sutures are then retrieved from the superlateral portal, and both ends of each suture are medially passed from posterior to anterior into the inserted tendon on the bony fragment with the use of a suture passer able to directly retrieve it. The same procedure is employed to repair the associated supraspinatus tendon tear. The suture's distribution is visualized in a better way with the scope into the superlateral portal. All the sutures are closed in a mattress type. The one limb of each suture are shuttled from anterior to posterior in the external eyelet of the Elite with the use of the violet vehicle, and are laterally tied respectively with their remaining 3 ends. Finally, with the scope into the lateral portal, the stability of the construct is checked in internal and external rotation.
Well, some technical tips and tricks. The tunnel preparation is necessary to stay below the fracture almost 1.52 centimeters, so to avoid the cracking of the cortex, and it's necessary to prepare accurately the lateral aspect of the humerus, so to remove all soft tissue and to see the entrance of your tunnel. Another important step is the augmentation. It's not solely to protect the bone, but also is a platform sutures, so you can manage your sutures to repair the calf, the associated lesion, and synthesize the bone. It's important to respect the bony fragment to avoid the splitting of it, and so the sutures are passed with the tools that you are confident through the tendon close to the tuberosity, but don't touch the bone to avoid the splitting. I like this to manage the sutures. I prefer the tape because it's not cord-like, because the pressure on the bone and on the fragment is better, and I don't like a sliding knot to avoid damage of the sutures and damage of the bone. This technique, I have also used this technique in a revision case, and it's possible to use this technique after removal the screw and the washer of the previous surgery. This technique presents a lot of advantages, the advantages of the transosseous approach and the advantages of the arthroscopic approach. And I have published last month this technique, and I say thank you also to my fellow. And for this reason, I was invited by Basim Fliga that saw this paper. But what's new today, Basim? Well, I had the opportunity to treat in the same manner the lesser tuberosity fracture avulsion in an old man in his 60s. This is the X-ray that you can see the red arrow, the lesser tuberosity avulsion. The CT scan and MRI evidenced the dislocation of the fragment and the associated lesion of the superior rotator cuff. This technique is similar but a bit different from the greater tuberosity fracture avulsion treatment, because in this case you have to perform two tunnels from the same entry point. The same entry point is in the anterolateral aspect of the humerus. First, perform the superior one exit point, and then with the scope intra-articular, you can perform the anterior tunnel into the crater of the lesser tuberosity. At this moment, you can shuttle your sutures, 2 sutures to manage the bony fracture, and 3 sutures to manage the associated cuff lesion. As for the greater tuberosity, stay behind the bone, respect the bony fragment, because the bony chips, if you pass with your tools you pass the sutures, you can split it and it could be a problem. After that, we are now ready to tie the knot, mattress knot, not sliding knot. To repair the cuff, I usually use the configuration that is called double MC, and after that, we can shuttle all the sutures, all the medial sutures, both the sutures employed to repair the bony chips of the lesser tuberosity and the sutures employed to repair the cuff into the lateral slot of the augmentation, that is the platform. For this reason, it's called a platform for sutures, and this is the final results. You can see how the repair may occur. In this technique, there are some technical aspects that are fundamental, such as the entry point, that you stay not in the medial part of the humerus, but stay more anterior, because otherwise your needle then don't come out. First, perform the superior tunnel, so the superior exit, and in this case you have to put the camera in the subacromial space. Secondly, you have to perform the second tunnel, anterior tunnel, so the anterior exit of your needle. In this case, the camera is intra-articular. The fracture management is respected the bony fragment, and the sutures are passed also for the lesser tuberosity as the greater tuberosity through the tendon close to the tuberosity. These techniques may present some downsides, because there is the need to change the camera location from intra-articular to subacromial and reverse many times. There is also the need to change the targeting, because if you have seen the targeting to perform the superior tunnel is straight, for the anterior tunnel is curved, and also there is a problem because you have to perform the anterior tunnel, I say, in the dark, because when you stay with your camera in the subacromial space, you can identify the entry point, but the exit point is you have to check the exit point with the camera intra-articular. So you have to maintain the tailor stitch in the pilot hole and then comes intra-articular. But there are a lot of advantages, and so there are a lot of bright sides that I have elucidated before. So in conclusion, with a transosseous augmented technique, obviously we can treat the rotator cuff tear and re-tear, but even if it's a demanding technique with a learning curve, I can affirm that it is a safe, reproducible, and efficient technique to treat both greater tuberosity fracture, and now I can add also the lesser tuberosity fracture. Thank you for your attention.
Thank you very much, Claudio, for this very interesting presentation. I will talk to you again in the discussion. Now, I have the honor to invite also our old friend to participate in many presentations in our webinars, Dr. Christopher White from Oklahoma. He will talk about periarticular locked plate technique in treatment of proximal humeral fractures. Please, Chris.
Thank you. Thank you for having me back again. Great talks. I truly enjoy doing this and spending time with you guys. Let me go ahead and get my talk ready. Everyone can hear me, right? I'm coming through?
Yes, we can hear you very good. Thank you.
Okay. Last time let's see if I can get my screen share going. And you can see my talk, correct?
Yes.
All right. So again, thank you again for inviting me back here. And I was asked to be, I guess, a bit of a counterpoint, but I think also to talk about fixation of fractures that perhaps wouldn't be amendable to arthroscopic fixation. And I was asked to talk about my technique, or a technique for treatment of proximal humerus fractures with the periarticular locked plate technology. And again, my name is Christopher White. I'm from the University of Oklahoma. I'm a faculty member there and have been so for over 15 years. As we all know, particularly the complex proximal humerus fractures, and even those that don't seem to be complex can be quite challenging. And Dr. Neer, in his landmark paper in 1970, of course, pointed out that these complex fractures oftentimes have unsatisfactory results or complications, particularly the 3- and 4-part fractures of the proximal humerus. When I was in residency in the late 90s, periarticular locked plate technology was catching fire, if you will, and we thought perhaps these periarticular plates would help us with these difficult fractures, with these fractures often occurring in patients with osteoporotic bone. And certainly we were using these quite commonly. However, the literature began to caution us that oftentimes these led to complications. And this was a paper that came out about 5 years after I went into practice in the American Journal of Bone and Joint Surgery, talking about displacement and screw cutout after open reduction and internal fixation with locked plate technology. And this was a review of 53 patients, average age of 52, and with an average follow-up of 31 months. And what they noted is they could get most of these fractures to heal, but not without problems. And they had a complication rate of about 36%. And they noted that age was significantly associated with complications, which we would anticipate, but there was no significant relationship between radiographic complications and the actual fracture classification. So at the time I started at the University of Oklahoma, I was the de facto shoulder and elbow trauma surgeon for our state's only level 1 trauma center for over a decade. And so we wanted to know how we were doing. It didn't seem like we were seeing the same degree of complications, but of course that's without looking at it, it's really, you can't really scientifically say. So we did a retrospective review of my first 3 years in practice, looking at the patients that I treated with open reduction internal fixation of proximal humerus fractures. And our inclusion criteria were those that, of course, were skeletally mature, so over 18. They had at least 3 months minimal follow-up, and I can touch on that later. And we did a radiographic review of all their x-rays, and then we reviewed their charts for complications. And we reviewed these patients. Let's see if I can go back to that last slide. Sorry. We classified them using the Neer classification scheme, but also the binary classification scheme discussed by Dr. Hurdle in his papers that were coming out around the time. We measured their neck shaft angle, both immediately postoperatively, but also at their final follow-ups. We also looked at the humeral head height relative to greater tuberosity. We also noted whether the fractures were varus or valgus in pattern. We noted whether they had the presence of medial comminution. We noted the size of the plates used, the number of screws into the head pieces, the number of screws we used into the calcars. And then we looked for the presence of osteonecrosis and other radiographic complications, such as screw penetration into the joint, plate, or screw failure, and also the presence of union. This is the binary, quote unquote, Lego classification scheme that Dr. Hurdle talks about. It's a modification of the Codman classification scheme that was, I thought was quite interesting. And of course, is the concept of each fragment in our four-part proximal humerus being a brick of a Lego that you can assemble in various ways. So on our patients, even though we're a level 1 trauma center and we see most of the high energy trauma in the state, the majority of the patients that I had treated for proximal humerus fractures were still those folks that had fall from standing height. But we also had those patients with more energy into their injuries, such as motor vehicle collisions, auto pedestrian injuries, crush injuries, farm injuries, and other industrial injuries. What was interesting is over 50% of our patients were type 3 or type 4, but we'd actually done 21% of our fractures we classified into a type 4 near classification injury. And this is reflected also in the binary Lego fracture description, if you will. 31% of our patients were in, 69% of our patients were classified to be in varus alignment, and 31% were classified to be in valgus alignment. So the technique used, step one was our approach. These were all open reduction internal fixation with the periarticular locked plate. So we use a deltopectoral approach, not a deltoid splitting approach for everyone. And our incision typically began at the tip of the coracoid and extended to the anterolateral of the humeral shaft. The cephalic vein was most often mobilized laterally, but occasionally medially. Just some tips on the approach and our technique. The incision needs to be more distal than a standard deltopectoral approach, as for example, in a shoulder replacement. And often incising the first couple of millimeters, the leading edge of the coracoacromial ligament will markedly increase your visualization of the subacromial space and those greater tuberosity fragments that are positioned in that subacromial space. We'd release a portion of the anterior deltoid insertion, and you have to allow for a positioning of the plate posterior to the pectoralis tendon insertion. And then at all costs, if we could, I would avoid a medial dissection around the calcar or inferior to the lesser tuberosity to maintain as much vascularity as possible. So the way I would manipulate the medial aspect of the fracture or the medial calcar would be to work through the fracture itself and not go through the soft tissue. Our step two would be to identify our fragments and mobilize those fragments. So you have to remove the hemorrhagic clavipectoral fascia, which at times can be very thick, particularly if the surgery has been delayed a few days. Oftentimes, I'd incise the periosteum posterior to the pectoralis tenos insertion in the bicipital groove, staying away from the arcuate artery. And this will often still be intact, but very thick, particularly if surgery is not delayed. I would place sutures in the rotator cuff to mobilize the greater and lesser tuberosities. I typically use a number 2 fiber wire or similar suture. And I'd use these later to tie to the plate if I felt they were well positioned. Our step three was fracture reduction. It was a valgus fracture, as discussed previously. Place a bone tamp or similar device on the lateral aspect of the humeral head and gently disimpact it into out of a valgus alignment to elevate the head into place. Oftentimes, if the rotator cuff's intact, there'll be enough hoop stresses or tension there. You won't be able to reduce it unless you incise the rotator cuff longitudinally. And that, what I would do is find a constant fracture line posterior to the bicipital groove and would incise the rotator cuff in line with its fibers just far enough to allow the tuberosity to move away from the head so the humeral head could be reduced. And then you can perfectly visualize the humeral head relationship to the greater tuberosity after that. If it was a varus fracture, I'd work through the fracture and elevate the humeral head back onto the shaft with a cob, typically, or some sort of elevator. If it's a 3-part fracture, I would use the sutures associated with the rotator cuff to assist with manipulation of the humeral head. Sometimes you'd have to use a K-wire if it was not attached to the humeral head for manipulation. And I would allow the medial head to shorten onto the medial calcar if I didn't have bony support. So if there was a ring of comminution medially, I would allow it to shorten enough to get adequate bony support. I would then provisionally fix the head onto the shaft. I would use a 2mm Steinmann pin placed away from where I intend to place the plate. I would then verify appropriate fracture reduction and then use the sutures to manipulate the tuberosities onto the head. I'd apply the plate provisionally, and while holding it reduced, fix the plate distally with a bicortical 3.5mm non-lock screw, drawing the plate to bone. I tighten the screw carefully and then pin the greater tuberosity to the humeral head through the plate with smaller Steinmann pins, and then verify reduction. Step 5 is the final fracture fixation. If you like your reduction, fill the proximal screw holes with 3.5mm lock screws, but great care, of course, has to be taken not to penetrate the subchondral bone, because that creates a pathway for the screw to go through bone if the head settles. And don't want to penetrate that bone with a drill bit or a screw, of course. And then I place the screws typically 3 to 5 millimeters shorter than I measured with the depth gauge. I then fully tighten the non-lock screw completely, fill the remaining screw holes distally with 3.5mm locked screws, typically because the older patient concerns of bone quality. If I placed a calcar screw, oftentimes I'd place it under fluoroscopy. And then I would use the sutures I use for manipulation of the tuberosities and tie these to the plate for additional fixation. We used mostly 3-hole plates, 3 holes being the holes in the diaphysis, and this is a Synthes pararticular locked plate. Typically 7 screws, but anywhere from 5 to 9 screws into the humeral head were used. Interestingly, we noted that we had 2/3 of our fractures had medial comminution, but I'd only used calcar screws in 21% of the time. And so how'd we do? Well, our neck shaft angle, we were really good about preventing that from reducing. So we did okay. Our immediate post-op was 131 degrees, and our final follow-up was 128 degrees. So only about a 3-degree change over time. We were able to maintain the humeral height relative to the tuberosity without significant displacement as well overall with the group. However, we did have complications, certainly. We had 4 patients had complications out of 42. That's around 10%. Of these 4 patients, there was 6 total complications. We had 3 that fell into varus collapse, 1 osteonecrosis, and 2 of them had prominent hardware or broken hardware. There were 2 additional complications, so a total of 6 patients had complications. The one with infection actually had a radiographic complication as well, but we had 2 patients without any radiographic complications that I did an arthroscopic arthrolysis and removal for hardware for stiffness. So if we did some statistics on it, we couldn't find any statistical difference in the classification, either by the near or the binary LEGO classification, with the risk of a radiographic or clinical complication. We couldn't find any statistical significance with varus valgus injury pattern or the use of calcar screws and the number of screws used. And we didn't find any significant difference in our patient age, which was a bit in contrast to the previous study. So as far as we could tell, all of them healed. And that, of course, is comparable to the JBJS article. We had about a 10% radiographic complication rate. We did have 3 of our patients, or 7%, fell into varus, which was lower than reported. Our final head shaft angle was very comparable. There was no difference by age, although they showed significant difference with age. And I think that's probably due to our lack of power in our study, I suspect. We found no difference based on classification either, and neither did they, interestingly. Now, we had a short follow-up. This was more a quality control review of my patients. And we because we're a level 1 trauma center, we have a lot of indigent patients who we couldn't get them to return for follow-up, but at least had 3 months follow-up. But our average follow-up was only 6.53 months. So, of course, with longer follow-up, we could have more complications. And their article obviously had better follow-up and for sure. So in general, or in conclusion, I'd say our technique was at least comparable to the published report. It doesn't seem to have the same amount of complications as reported. Now, my review was limited to my first 3 years in practice at the university, but my technique has largely stayed the same. Currently, I did another CPT code search on my database, and I've done over 250 cases of proximal humerus fractures in my 15-year plus career here at the University of Oklahoma. Now, interestingly, none of these were greater tuberosity or lesser tuberosity isolated fractures because our code for treating that is different, and so they're not included in this number. These were just those that we fixed with plate fixation. And obviously, I need to revisit those results and gather better clinical data in addition to chart and radiographic reviews, because I think that's a wealth of cases that hopefully I can tap and find some interesting information. So again, thank you for asking me to participate and to share my experience.
Thank you, Chris, for this very nice presentation. Now, the next presentation, I will present it. What's this? No. Sorry for I'm sorry for that. One moment. Yeah. Okay. So in this presentation, I will talk about 3 to 4 parts proximal humerus fracture reduction and suture fixation using arthroscopy. As said before, about 4 to 5% of all fractures are proximal humeral fractures, and 71% of these fractures occur in patients above 60, and 60% of the cases are with osteoporosis. Now, the treatment of 3 and 4 parts fracture according to NEAR classification is percutaneous fixation or open reduction and interfixation or prosthetic replacement, and as was said before in previous presentations. But to our knowledge, there is no arthroscopic treatment present in the literature of 3 to 4 parts fracture. Now, in 2011, we developed an arthroscopic technique of reduction and transosseous suture fixation of 3 to 4 parts fracture of the proximal humeral fractures. Now, we do this technique for all 2 parts fractures, most of the 3 parts fractures, and some 4 parts. It is applicable for all cases, including cases with osteoporosis. The strategy of this technique is to have an arthroscopic reduction of the bone fragment and fixation with temporary K-wires. Then the fragments are sutured together. The temporary wires are removed, followed by a post-operative immobilization for 3 to 4 weeks, then starts exercise. The position, as mentioned before, is a sitting position with the standard 4 portals, maybe more. Now, the suturing system we use are 3 suturing systems. The giant needle suturing system, transosseous suturing system, the penetrating suture wire system. It is a wire with a suture fixed to its proximal end and a hand grip of its distal end. And the suture wire system, which is a wire with a hole at its distal end to pass the suture thread. Also, some special instruments we like to use is the concave node pusher. It helps to pass a sliding node and placing it in the place we need to or we want to, and the chop needle suture puller to pull the suture from the subacromial space through the skin from any place you want, not depend on the portal. Nowadays, for every case, we do a PSI model to evaluate the displacement of the greater tuberosity, the lesser tuberosity, the head, and its rotations. And that's helped us very much in the planning of the surgery. Now, the types of the arthroscopic reduction and suture fixation are the short vertical transosseous fixation with the giant needle, as described by Dr. Sharif. The horizontal transosseous suture fixation, also described by Dr. Sharif. These are mostly used in 2 parts fracture. And the mattress transtendinous fixation and the long vertical transosseous fixation, which is mostly used in 3 and 4 parts fracture. And if we use all of these together, they will make the same symbol as the NATO, so we call it NATO fix technique. The strategy of this reconstruction is based on reduction and fixation of the head to the shaft and fixing it with K-wires, then reduction and fixation of the greater tuberosity and lesser tuberosity on it, either if it is 3 parts or 4 parts, and suturing them with a mattress suture, and then suture all these together to the shaft with a longitudinal vertical suture. Now, in the 3 to 4 parts fracture, the head is mostly in varus angulation or valgus angulation. So the reduction is done for valgus angulation by abduction and rotation, and then fixing it with 2 K-wires. This is the first step. In case of valgus angulation, we go with a spatula and push the head a little bit up to get it as much as possible in its anatomic position, and then fixing it to the shaft with the K-wires. We go with the K-wires distal or at the insertion or near the insertion of the deltoid. Now, in some cases with valgus fracture angulation, the greater tuberosity is displaced posteriorly. So the first thing we do, we reduce the head, fix it, and then reduce the greater tuberosity and fix it also with K-wires. As we see here with a sharp hook, we are putting the greater tuberosity to its anatomical position and fixing it with K-wires after fixing the head to the shaft. Now, the second step, we do the mattress suture fixation of the tuberosities. This is by passing the giant needle through the tendon of the greater tuberosity, which is mainly the supraspinatus and some of the infraspinatus, and another suture through the subscapularis. Then the 2 lower ends of the suture will be pulled out through the instrumentation portal and tied together. After that, we pull the one upper end to pull the knot through the tendon outside the joint and cut it in order to have a suture without knots passing through both tendons. And then we make a sliding knot and push it together, push it inside the joint to compress the two tuberosities together on top of the previously fixed head with the shaft with K wires. After that, we put a guide on one of the K wires, fixing the shaft to the head. And then we remove the K wire and put in this tunnel the penetrating suture wire. So we can place the suture inside the joint. And then we cut it from the wire and put it with a chop puller immediately above the insertion of the supraspinatus outside through the instrumentation portal. And we pull the lower end and tie the two fragments, the head, with the previously fixed tuberosities to the shaft. In some cases, if we want to use a special suture, we use the PS wire, the penetrating suture wire, as a loop and pass the desired suture through this loop and pull it through the bone and then tie it in the same manner as before. By doing this with an horizontal suture fixation for security, we get the NATO fix technique repair. Now, this is the case of forefoot fracture with the head splitting and a virus impacted humerus. Here we see the head with a splitting fracture. And this is the fractured greater tuberosity. And there is a part of the head bone is fractured and displaced superiorly. Now we abduct the arm and pass the two K wires to fix the head to the shaft. And then we pass the two giant needles, one through the tendons of the greater tuberosity and the other one through the subscapularis. We have the sutures now passing through the tendons, and then we make our mattress suture. Now, after having it passed, we pull the two upper ends and then tie the suture firmly using the concave knot pusher, and compress the two fragments together. After that, we go to the wire, remove it, and put the penetrating suture wire with the suture from the shaft through to the head. And here is the penetrating suture wire with the suture going proximal to the head. We first use a ring forceps to pull the suture from away from the wire, so that we can pull it easily through the instrumentation portal above the insertion of the supraspinatus. And that is done then by using the chop needle puller, which is passed, and then we pull it through the tendon. After that, we make our sliding knot and fix the head with the two tuberosities to the shaft, and we review that for another suture or two or three sutures. And here is inside the joint after fixing the head and the fragment, and the suture is compressing the fracture inside. In some cases, we use a giant needle again to secure this fixation. But when we do that, we have to keep the fixation wires before doing that. in order to avoid displacement. This is the case before surgery, showing the greater tuberosity fracture. And after surgery, we have a fairly good anatomical reconstruction. We reviewed 22 cases of 3 to 4 parts fracture from 33 cases done with arthroscopic treatment. The average age was 60 years. The average follow-up was 2.5 years. There were 18 cases with 3 parts and 7 cases 4 parts fracture. Rotator cuff tear was present in 3 cases, and 72% of the cases had osteoporosis. The result, half of the 3 parts fracture had excellent results. The other half were satisfactory according to Neal classification. While the 4 parts fracture, 29% were excellent, 42 were satisfactory, and 29 were unsatisfactory results. The complications were in 2 cases, 29% of the 4-part fractures were malunion, and 21% of the 3 parts fracture, while impingement symptoms were present in 2 cases. In conclusion, summary, the clinical and radiological results strongly encourage using the arthroscopic technique to treat proximal humeral fracture, especially in all patients with osteoporosis. Age and osteoporosis is not a contraindication. There is no complication of osteonecrosis or non-union because there is no disturbance of the blood supply. And it has a minimal morbidity. It's a 1-day surgery, which is accepted by all patients. It is also a low-cost surgery. Thank you very much for your attention. Hello? Can you hear me?
Yes, we can hear you.
Yes.
Yes, I can.
Okay. I can hear you, but I can't see the picture. Anyway.
You want to end your presentation?
Yes, it is already ended. Now we go to the part of any questions. To the first participant, Dr. Hani, is there any questions? Dr. Hani? I have a question for you, Dr. Hani. There's a question. What would you do if a patient refuses to do open surgery because he's old? I say, I don't want to stay in the hospital. Would you go for conservative or try to do an arthroscopic treatment, especially if it is 2 parts fracture?
Yes. In all cases, we have to discuss with the patient carefully because some patient expectation about the surgery is very high. So we have to discuss with the patient very good. We need to see the condition of the rotator cuff. In old age, it may have some arthropathies on the rotator cuff. And we need to know what is the expectation of the patient, what he needs to do by his own. if he need to do some job with his arm, I will discuss with him, even arthroscopy. But a small comment about arthroscopy, it's a high-level surgery. So I think it have to be arthroscopic surgeon, not general surgeon. So it have some talent or some experience on arthroscopy. I know I do some cases with you before. So I will discuss with him if he agree to make some reconstructions by using giant needle or even suturing of the fractures and start early physiotherapy. I think it will be better than completely conservative. Because if we can go conservative, we may, I wait until 3 weeks. In some cases, when they start physiotherapy, they have some displacement on the fractures. So I think arthroscopic on low demand patient also better than completely conservative. And this is my opinion.
Okay, any comment to this from the presenters?
Actually, I have a question. Maybe this question is for both Dr. Hani and Dr. Christopher White. If you already decided to do open reduction internal fixation, and then during the follow-up, the patient began to develop a vascular necrosis, what are you going to do? Are you going to remove the plates and screws? What's your strategy if during your follow-up you found that there is signs of a vascular necrosis?
So my experience with osteonecrosis is, it can certainly happen in a delayed fashion. And my routine protocol for my plate fixations is typically they're healed, and I see them by 6 months, and then I see them at a year and at 2 years to watch for avascular necrosis. And what's been interesting to me is we actually did start a pilot study where we were reaching out and retrospectively bringing in patients that are quite a bit further out, like 5 years or so. And every once in a while, you'll see a patient that would come in and see us, and they'd have avascular necrosis and were seemingly asymptomatic from it. So, the reason I wanted to follow them for 2 years was to look for osteonecrosis. And if the bone died back around a screw, then obviously I'd want to take that screw out. But I don't think the osteonecrosis itself sometimes is terribly symptomatic, and I think patients will have part of the head will die, but not the entire head will die. And at least in the intermediate term, if you will, they'll do okay. So in general, if I see a spot of avascular necrosis that is making a piece of hardware prominent, I'll remove that, because my concern is it'll braid against the glenoid. Now, one thing that's kind of interesting about osteonecrosis is I had one patient that had just a perfect looking x-ray and just had a lot of pain. And she was a workers' compensation injury, and I could not for the life of me, her cuff was intact. She, her reduction looked great. She'd healed, and she just hurt. She hurt and hurt and hurt. And at 2 years, then she started developing radiographic evidence of AVN. And so I do think that patients that have pain sometimes out of proportion to what you would think based on the radiographs, if they hurt a lot, I'm starting to suspect that some of those folks have AVN, and I just can't appreciate it. And as you guys know, with all that hardware in the humeral head, you can't really image it to get a sense until you see it radiographically, because you're not going to be able to get an MRI that's going to be able to show you that. So I guess a long-winded way of saying, if AVN can happen, I think sometimes it's asymptomatic. If it occurs and the hardware becomes prominent, then obviously I'll remove it. If you get complete head, AVN and collapse, then you're going to be left with an arthroplasty.
If you suspect an AVN, and some surgeons, they do a drilling of the head, even arthroscopically. Do you do that, or do you have any experience with that?
Yeah, I do, but not in the setting of trauma. So, if patients have drug-induced or, some medical issue that's initiated AVN, I've cored or drilled a fair number, and I've been shocked with how well that helps them with their pain. I don't know how much it affects the natural history. So I think it's similar to a cord decompression of a femur, in that, I think that there's pretty good support that it helps them symptomatically. Whether it actually alters their natural history down the road, I'm not for sure. There are some patients that I know have had real early, pre-radiographic, in other words, not on X-ray, but MRI evidence of AVN. I've cored them; they've done a lot better, and then I've had opportunity to MRI them later on, and they seem to have recovered and healed. Whether they would have done that with or without my intervention, I don't know, but certainly it helps their symptoms. And I do have a fair bit of experience with it, and I've been actually more encouraged than I thought I would by doing it.
Thank you. I have a question to Dr. Sharif. Do you do the arthroscopic surgery for all ages or only all patients?
Yes. Thank you very much for the question. Although open surgery in young patients have good results, I do the arthroscopic surgery for all ages because it's less traumatizing one-day surgery.
Okay. Then another question also, do you use both fixation technique, the vertical and the horizontal, for fixing the greater tuberosity in all cases, or according to each case separately?
No, according to each case separately.
Okay. I have now another question to Claudio. Do you do this procedure in cases of osteoporosis?
Well, sure, Basim. It's indicated in patients with low osteopenic bone or osteoporosis because the cortical lateral augmentation provide a good fixation, and from a mechanical point of view, you close the loop because you have the slot in the elite. In the anterior slot, you put your sutures, then the sutures pass through the tendon, through the bone, you close in a matrix type, and then you can put your sutures laterally, so you close the loop, and from a biomechanical point of view, it's a really strong fixation. So there is no contraindication to use this technique in porotic bone.
Okay, I have a question to you also. After placing the sutures, do you first tie the rotator cuff and then the fragment, or you tie first the fragment and then the rotator cuff in the ATA technique?
Well, I start to close the knot, to tie the knot from posterior to anterior. So if the fragment is posterior, I tie the knot for the, I tie the knot from anterior to posterior. So if I have the cuff, I repair the cuff anteriorly and then go back to the fragment. For the lesser tuberosity, it's different because I can tie it first anteriorly, the lesser tuberosity, and then go up to repair the cuff.
Okay. I have now a question to Chris. Do you use do you use this technique for all cases, even two parts fracture, or do you use sometimes arthroscopic fixation for two parts fracture?
I have done some arthroscopic fixation for a two-part greater tuberosity fracture in the past. My hat's certainly off to you folks who are very skilled at transosseous techniques, and that's something that's not something I am terribly familiar with. With the arthroscopic techniques I use, years ago, I tried those with anchors, and in younger people, I think that can be useful, but you guys clearly point out and recognize, of course, that's not great for older folks with bad bone. So in general, for me, with greater tuberosity fractures, I've gone through, kind of run the gamut on how I fix those. Like I said, doing those arthroscopically or arthroscopically assisted early on, and then, with larger fragments using sometimes percutaneous screw fixation that I would assist arthroscopically. I agree completely with everything that's been said. That runs the risk of comminuting these fragments, and wasn't very satisfied with those, except for in young guys or with good bone. And ultimately now, I've gone through deltoid splitting approaches to fixing the tuberosities, using a screw as a suture post, because recognizing that the point of fixation failure oftentimes was the suture pulling through the lateral cortex, because it's so thin there. And now I use a small little T plate and do sutures through the tendons, not through the bone at all, adjacent to the tuberosities, and tying to the T plate as my point of fixation. And for me, that has been the most reliable way to fix it. But again, I'm not facile, if you will, in transosseous arthroscopic techniques. So again, I think what you guys are presenting are great. That's just something that I've not done much of.
Thank you.
I have a question to Dr. Christopher White, if you allow me.
Yes, please. Yes, sir.
Your huge experience, 250 cases in fractures, 3-part fractures, 4-part fracture. Did you ever meet a fracture during your surgery having a rotator cuff injury? I mean, as you mentioned, you like to remove a part of the coracoacromial ligament to expose the subacromial space. Did you meet rotator cuff injuries, and how do you treat them?
So, surprisingly, and I need to look this up. I'm so sorry. I've got a large volume, and so I can't tell you for certainty, but I think early on in my career, I was kind of shocked that in these older patients, I wasn't seeing more cuff tears. I would venture to tell you that I would see cuff tears in probably less than 10% of the folks that I have done open reduction internal fixation on with plate osteosynthesis. I think it's probably because our patient population at the trauma center is a bit younger. So, we're seeing folks that there's a fair bit more, industrial injuries and motor vehicle accidents. And so I think I'm getting a patient bias, selection bias based on age. And the folks that have cuff tears, being able to, more often than not, I'll do a cuff repair associated with the fracture fixation, and those little holes in the plate that I'll tie to are perfect anchor points for sewing the tendon to. So I'll just incorporate it in the fracture fixation itself and into the plate itself is the way I'll fix those. And it seems to have worked well, again, but I think it may be skewed a bit because the patient population I'm seeing is, I think, a bit younger.
Thank you.
I have another question to all participants. How about anatomical neck for dislocation? Is it amenable for fixation? So this question I pass to Dr. Hani. How about anatomical neck fracture dislocation? What do you do for that with open surgery? Dr. Hani?
I have nice history of vascular necrosis. A question for Dr. Chris. Yes, I'm here. You can hear me? Hello? Hello?
Yes, we hear you.
Here, yes. I have very nice history regarding the question of vascular necrosis. I see patient after 6 months from fixation, proximal humeral fractures, they come just complain from clicking only. And the very, very strange X-ray, the X-ray show plates, the proximal humerus is there, screw is fixed, and the head completely resorbed. So I think the post-traumatic avascular necrosis is different from the regular avascular necrosis. So we have to consider, on myself, I consider Herter criteria. If I put Herter criteria and found it, medial calcar is not there, displacement of the posteromedial corner and the comminution and fracture through the anatomical neck, I will discuss for the patient. I think we have to proceed from the start with arthroplasty. I will not do the patient on high risk of avascular necrosis, as we see the Hertel criteria, and put a fixation and end with avascular necrosis. So I think if the Hertel criteria is 3 point as positive, we will go for arthroplasty.
Dr. Sharif? No, I think Dr. Sharif is not here. Okay. Claudio, what do you do about anatomical fracture, anatomical head fracture dislocation? Do you proceed? Claudio?
Yes, sorry. Yes, okay. It's not possible to use the technique, the ATA technique, but if it depends on the age of the patients and the time from the trauma to the surgery. Because if pass a week or more, probably that the head will go in avascular necrosis. So if I have a patient with a delay in the treatment, I prefer a prosthesis in the old patients. Otherwise, I think that the better solution, we can try to synthesize the fracture, obviously.
Thank you. Chris?
So I think as pointed out, I think the age, health are critically important for me to make a decision if this is a patient that I'm going to move straight to an arthroplasty or not. Dr. Hurl's papers are great, and I think it was laser Doppler flow analysis of ischemia, and those findings on that paper were of acute ischemia. I believe he had a follow-up paper that showed that the correspondence with AVN down the road wasn't quite as good. And so I use those criteria predominantly for older folks. If I think it's a humeral head that just doesn't have a good chance of remaining viable, then that's going to be an arthroplasty patient for me. But if I had a 38-year-old, patient with a humeral head, anatomic neck fracture, I would give them a chance to heal if I could. And so I would try to fix the younger and active folks. I know there's an article that came out, and I'm sure there's more than just one, that talked about how delayed arthroplasty isn't as effective as acute arthroplasty. Now, of course, that applied to hemiarthroplasties that we used in the past, and most of those are doing reverses now. So maybe that's not quite as applicable, but and I realize that maybe there is a detriment to trying to get fixation if they don't heal, but I'm not for sure if you're able to restore and get the tuberosities to heal, then you have a much more straightforward arthroplasty to perform down the road. So in younger folks that I think have a decent chance of healing and maybe salvaging that humeral head, I will try to fix it. But in folks that are elderly, lower demand, or medically not well, I will do an arthroplasty in that case.
Thank you, Chris. I will answer also this question. Actually, I agree with you. The age actually is the key point. In a young patient, I did that also for several cases. I do an arthroscopic fixation if it is an isolated anatomical neck displaced fracture. I make a reposition arthroscopically and fix it with the giant needle. And I didn't do a lot of cases. There are maybe 4 or 5 cases, but all the cases went well, and I didn't get any information later if anything happened. In all cases, actually, all patients, they are concerned to go to the hospital and stay a long time and so on. So I just give the choice either to do a head replacement, which is a safe, a procedure with good results, or we do arthroscopic fixation, but I don't guarantee the results. So actually, I advise to do a head replacement in all patients unless he refuses to do that. So I will offer him an arthroscopic fixation, but without guarantee of the result. Actually, I have other question for me. I will answer, but there are actually many questions, but because of the time, I will just say the question and ask for a short answer. The question was, when do you go directly to total shoulder replacement? Chris?
Older patient or an unhealthy patient with a 4-part proximal humerus fracture, a humeral head that I feel strongly is going to be ischemic and likely to develop osteonecrosis.
Claudio?
Totally in agreement.
When do you go?
Christoph. Totally in agreement with Christoph.
Okay. And Hani?
I also agree.
Yeah, I agree too with Dr. Chris.
Obviously,
Now,
Hazim, obviously, yes. we refer to the reverse prosthesis. Because in elderly patients with the calf, with a bad calf, I prefer to replace with a reverse, not anatomical.
Yes,
yeah.
Sure.
Okay.
Okay. Now a question about the arthroscopic surgery, the cost of the surgery. So I think this question will be to me and Claudio. So Claudio, the cost of the surgery of arthroscopic fixation of 2-part fracture.
Well, the cost is not so high if you with the instrumentation that I use. There is only the needle that is disposable. It's single patients, not single use, but single patients. And the cost, I don't know the cost of the material in other countries, in your countries, but here in Europe, in Italy, the cost of the needle, it's comparable, and it's lower than the cost of an anchor. While the implants, it's similar to an anchor. So the cost is not so expensive, I think.
Okay, for me, by using the 3 systems, the giant needle, PS wire, and the suture wire, the cost also are, the whole cost is similar to one anchor. So it's not a very high cost, actually. And there is the question, I think the last question, it is addressed to myself. They're asking, if you have a comminuted fracture, what are the anatomical landmarks to distinguish the fragments? Actually, if we have a comminuted fracture, the landmarks for me is the insertion of the tendon. So the greater tuberosity is fixed to the supraspinatus and infraspinatus, and the lesser tuberosity is fixed to the subscapularis. So by doing the mattress suture, I pass the suture through the tendons and of both tuberosities, and then compressing them together. So if we have a comminuted, I will compress the bone of both tuberosities together by tying the tendons to each other. So actually, for me, the landmark is the insertion of the tendon. And what about you, Claudio? If you have a comminuted fracture, what are the landmarks for you?
Well, sure, the insertion of the tendon, but
if you have a comminuted fracture, what are the anatomical landmarks to distinguish these fragments?
Well, Basim, I have no experience to the treatment of arthroscopically of 4 parts or 3 parts as you.
No, no. The question is that if the fragment is comminuted fracture.
Oh,
so,
okay. But if the fragment is comminuted, it doesn't matter. You have to repair the tendon.
Yeah.
You have to reattach the tendon.
Okay. Thank you very much. We have many other questions, but I will just ask the participants if anyone has a question for us or for any other participant. So I don't think. Okay. Now I think we come to the end of our webinar. It was a very nice webinar. Thank you all very much for your participation from Italy to Oklahoma. And we wish to see you actually in Cairo anytime. Maybe in next end of September, October. We will be very happy to see you then.
Thank you.
I want to make 2 announcements. First, the next webinar will be on large and massive rotator cuff tears when arthroscopic and when open. It will be next month on the 4th of June, also on Friday. And I want to announce also our annual meeting, which will be the 29th of September and the 1st of October. It will take place in Cairo. It will be a very beautiful weather at that time. And you are all invited to come to visit us and to participate in this meeting. Thank you very much again, and wish you a nice evening or a nice afternoon, and see you next time. Thank you.
Thanks again.
Thank you. Hi, guys. Ciao.
Hi.
Ciao.
Bye-bye.
Arrivederci.
Ciao, grazie. Thank you.
Later.